I work in the emergency department at Bayshore. I've been here for 2 years, and I take care of patients, any patients that are brought into our ER, either a walk-in or through ambulance. Every life, unfortunately, will end in death, and there are some cases where it's expected death. And the ones that are really tough are the preventable deaths. The ones that life was taken away prematurely, and those are the ones which we treat them medically, but emotionally, not only for myself but for the entire staff. Those are the ones that are like, is there something that we could have done before they got here? Something that we could have intervened with, just not us as physicians, but as a society, to prevent that death. We see everything from the small paper cut to the coughs and colds, to the patients who are having strokes and heart attacks, to gunshot wounds, infections, pneumonias, heart attacks, broken bones. Basically, we see it all. We're a community hospital that takes care of 37,000 patients per year. We serve the surrounding communities. We're able to handle everything. It's whatever you can think of that you've seen on TV, that you've been afflicted with yourself at home or know of family members or friends who have. That's all and more that comes to our emergency department. Over the years, our numbers have been increasing with not only opioids, but all types of polypharmacy and polysubstance abuse, ranging from the big two are alcohol and opioids being prescription medication as well as heroin. And then we see a variety of other substances, everything from benzodiazepines, things like you may have heard of Xanax or Ativan, to cocaine, marijuana, a variety of antipsychotic overdoses. But the big two definitely are alcohol overdoses as well as opioids. I think for alcohol, there's clearly a genetic component to it. There's a mental health component to it, and there's a social component to it. There's a lot of social stresses that cause people to slowly start drinking. And clearly, there's a lot of literature saying that there's a genetic component, that if your father or your mother or someone in your family is an alcoholic, there's a higher chance that you will be as well. And it's a downward spiral. You start with a few drinks. There's more social stresses. You have a lower threshold of having alcoholism in your family. And therefore, you have, unfortunately, a higher risk of becoming an alcoholic. With drugs, with opioids, a lot of it stems from the prescription opioids that patients are started on. They get a few doses because they injured their back, they had a fracture, post-operatively, their surgeon gave them some prescriptions, and they were supposed to only take it for a few days. And then they're like, oh, this feels really good, and I still have a little bit of pain. Let me get another prescription. And the doctor's like, okay, one more. And then finally the physician and the providers are like, no, we're not giving you any more. And then they start resorting to getting the medication off the street illegally. And then if they're addicted or have a substance abuse problem, then they resort to heroin or synthetic opioids such as fentanyl. And it's very prevalent in Monmouth County. There's some clearly key hotspots within Monmouth County that these illegal substances, especially opioids, are available. So alcoholism, there's a variety of survey questionnaires that are been validated that you answer that will tell if you meet some of the criteria for alcoholism based on specific diagnosis codes. But in general, it's a spectrum. Is it impairing your function at work? Is it impairing your function at home? Are you requiring the use of alcohol to prevent withdrawal symptoms? Are you getting a drink of alcohol first thing in the morning? Have you lost your job? Have other people complained about your drinking? So it's a lot of these types of questions that providers and physicians will ask of a patient to determine what spectrum or where along the spectrum they are of alcoholism. So medically, it's a dependence where your body requires that substance to prevent withdrawal. Okay, so for example, in alcohol, you may be, or some of you may be aware, that people start shaking, all right? And that is an actual withdrawal symptom because their body is so dependent on the substance, in this case being alcohol. So what do the patients do? They drink alcohol to prevent that withdrawal symptom. Now, that's a very mild withdrawal symptoms of just some mild tremors. It can get even to more extremes where people can get delirium or delirium with tremors, and when often known as DTs, people use that term. And that's a very severe form of alcohol withdrawal. Patients usually need to be admitted to the hospital to an intensive care setting. So similar with opioids, patients will get withdrawal symptoms if they don't get opioids within a certain period of time, and they need an opioid just to prevent some withdrawal symptoms. And that could be everything from insomnia to nausea, vomiting, abdominal cramping, diarrhea, or just not feeling well, and they'll need a quote-unquote hit to restore their levels because their body has developed a tolerance and a dependence to that drug. It's mainly in the neurotransmitters. So to give you an example, if you have a normal cell and has, say, for example, 10 neurotransmitter receivers on it, and all of a sudden it usually gets 5 of them filled. And now all of a sudden you add in alcohol or any other substance, and now it's firing off and it's getting overstimulated. And your body's like, wow, I like this feeling. And they're like, okay, maybe I'll develop more receptors. And now only half of them are filled, or a third of them are filled, but like, I want more. So therefore, ends up the cascade of requiring and needing more because there are some biochemical changes which occur within the brain, within the neurotransmitters, within the receptors, which end up in dependency and requiring more and more of that substance in order to prevent, again, the withdrawal symptoms. So alcohol, I would divide that into 2 categories. One is the non-alcoholic who binge drinks, because of a party, a concert, a graduation, whatever it may be, is not an alcoholic, and they just drink way too much and they overdose and they come into the emergency department, right? And then there's the alcoholic who they are dependent on that alcohol. They're in a social environment which allows them to drink so much, and they come in intoxicated. So for both those cases, one is more counseling for the one who binge drinks and say, hey, you put yourself into a very serious situation. It's a little bit easier to communicate with them. They realize and understand the harm they did to their body. And hopefully they won't do it again, or it won't be as frequent. The alcoholics, unfortunately, is much more intensive. They need a lot of outpatient support services. And it's very hard to break their cycle. They need a lot of family support. They need a social structure, which they need to be a part of, whether it be AA or an acute rehab center. And then even when they're discharged from those rehab centers, they need to go back to an environment which hopefully will reduce the likelihood or prevent them from going back into their old situation. For opioids, it's a little bit more complicated in the sense that there are those members of society who just use it, for the first time. They don't know how much they're using. They don't know what they're exactly taking and what the potency of it, depending on how it's cut and how it's formulated, and if it's mixed with anything else. And they may overdose, and what happens is either a family member or a friend realizes that they're not responsive, and they'll need to be brought into the emergency department, and hopefully we can save them or reverse them. And then there's the ones who are chronic users who, for whatever reason that day, they took an extra hit or an extra 2 hits, or the formulation that they used was a little bit different from a different supplier, and they weren't aware of it. And then there's the unfortunate patients who use their parents or their family members' prescription opioids, and they take too many of those. So it's a variety of reasons why they overdose, and what category they are, and how they're brought in. So in Monmouth County itself, in 2016, I believe there's about 160 opioid overdose deaths, right, which is skyrocketed over the years, not only in Monmouth County, but in all counties in New Jersey and throughout the United States. So those are confirmed deaths. Many of those deaths, unfortunately, occur before the patient's even brought to the emergency department. Okay, so again, the scenario is there's a group of people. Actually, it could be an individual who decides to use an opioid, and they're found by a family member or a friend the next morning, unresponsive, no pulse, and they're not even brought to the emergency room. Then there's those patients who are found unresponsive. They're still breathing. Someone calls 911 or EMS. The police or EMS show up. They try to reverse and revive the patient on the scene, and then they're brought to the emergency department. Those are hopefully we can save. The actual number of deaths in the ED that occur, I don't have the exact number, but it's a fair amount. But I'd say even the greater amount is patients who just die before they make it to the ER. Alcohol and opioids, the sedative effects and the respiratory depression and respiratory arrest or stop breathing is compounded. There's change in mental status with the alcohol and the opioids may allow the patient to do things that they would not normally do, which causes them to get injured or die. So it's definitely, as I mentioned, an additive effect of both. Clarify that. You will not be arrested. Okay, if you come in with alcohol intoxication, now unless you get into a car accident or there's some type of criminal activity outside of just the use of the substance, you will not be arrested. Okay, so if you're overdosing and you hurt someone, damaged some property, got into an accident, that's another aspect of it. But if you just come in, you're home, you overdose on any medications or substance, we will treat you, we will discharge you. You will not, none of that information goes to the legal authorities. Okay. Now, there's a lot of reasons why patients with opioid use and even overdoses, there's a range, may not want to come into the ER outside of the legal ramifications, which again, there are none. Hey, they're high. They don't want us to reverse that high. They spent money on getting to that state, and therefore, they call 911, we're going to reverse that, which is what they don't want. The times when they call 911 is when their friend, colleague, family member is unresponsive. That's when they call them. And often what happens is by the time EMS gets there, they will reverse them on the scene. The patient will awaken and become alert and oriented, and then will refuse to come to the emergency department. Because they're like, I'm fine, I'm okay, I know what you guys did, and they have the right to refuse at that time. As much as the police and EMS would want to push them to come seek treatment, unfortunately they have the right to refuse.
Sorry, you doing so good. What's the matter, brother? Come on, man. Dude, you okay? Holy shit. Jack. Come on, man. What are you doing? You gotta wake up. What do I do, man? Come on, man. Wake up. This ain't good. I'm gonna have to call the cops, dude, or the ambulance or something. Come on, man. What are you doing? God. Hello?
911 emergency response. How may I help you?
My friend's keeled over on the floor. I don't know what to do with him. He's just hit the floor and he's not breathing. He's like turning blue, and I don't know what he's doing.
What is the location of the emergency?
It's 7 Ocean in Middletown.
Can you provide me with the cross streets near you?
I think it's Menudo Drive.
EMS.
Oh man, they're here. Thank God. Okay, can I hang up? Okay,
Yeah.
all right. Come on, guys.
Okay. Why don't you sit down?
What's up?
What's going on?
We're just sitting here playing some music, and he just stood up and he fell over. He got up. His name is Jack.
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 Jack, are you with us?
Jack.
Okay.
Here's my blood pressure cup.
Name
I'm
is,
gonna do the blood
Midas?
pressure cord. Can you do the pulse and respiration for me?
Yeah.
And look at the pupils also.
We were smoking some weed and we were sniffing some oxy. And,
So both of you were doing it?
yes, sir. Am I in trouble?
No, not at all.
He just fell over. I've never seen this happen before.
Okay, so he's never seen him overdose on
On anything now.
Okay.
I'm just checking his blood
Do you know
pressure.
his birthday?
I'm checking
Sometime in
his
July of
pupils.
'58.
I'm getting information from the bystander about who he is and what happened.
He over 76,
I don't
how are his
know. I
pulse
don't
and
think so. I mean,
respiration?
he might
Pulse
take
is
a
at
heartburn
110,
stuff or something.
respiration's
I
at
don't know
6,
really.
and his pupils are constricted bilaterally.
All right, we're gonna start
I don't
bagging
know.
him.
You know, we're friends. We play music together. I don't really know.
My name's Rachel. I'm the EMT for Fairview, and I am checking his blood pressure, and we're checking all of his vitals. We want to see if his respirations are depressed to about 8 or so. That indicates that he might be overdosing. So we're setting up the bag
Is he gonna be
bomb
all right?
bags
You
and
got-
the
we're
Doing everything we
oxygen.
can. Just sit down.
He doesn't look too good.
I am checking his pupils. I also checked his pulse. I want to see what his heart rate is and if his pupils are constricted or not, because that could be a sign of overdosing. Hook it up to the oxygen tank.
So, how many pills did you take?
I am assisting Rachel and Corey with getting everything ready.
How
I'm
many
gonna-
liters? He had 2. I
15.
think there's one in his pocket or something. I don't know.
I'm going to set up the Narcan to be
He cut
administered.
him up and we just snorted
Be
him.
2 milligrams administered, 1 in each nostril.
Okay, 15 liters.
Corey.
Come on,
Are you ready?
Jack.
Yep, I'm ready. All right. 1 milligram in the left nostril, 1 milligram in the right.
Back to bagging.
Let me get reads.
Yes, can you get the reads?
120 over 76, pulse is 110, and respirations are 6. His pupils are constricted bilaterally. And we're bagging him now. We give him 2 milligrams of Narcan.
Is he gonna be okay?
We're doing everything that we can, okay?
Please sit down. We're gonna load him up and take him to the hospital.
Put your arm up over here.
Maybe just slide it up a little.
Come on, Jack. Come on. Come on, Jack. You're gonna be all right
All
now.
towards us. Ready? 1, 2, 3. Good.
Jesus.
And now back towards Django. And we'll buckle the straps down.
Come on, man. Hang in there, Jack.
So for opioid overdoses, it stops their breathing, so their respiratory rate just starts to diminish until they stop breathing altogether and die. So what Narcan does, it reverses those neurotransmitters I was talking about earlier, allows them to start breathing again, become more alert, oriented, and we or the pre-hospital providers, the police or the EMS intervene. For alcohol, it's again a sedative. So with alcohol, often they become altered mental status, and they can either die from the alcohol intoxication itself, where they can potentially stop breathing, but more often what happens is they vomit, they aspirate or choke on their own vomit, or they get injured from their intoxicated state and injure themselves or do something bad to themselves in that intoxicated state, which causes the injury or death. There is no barriers when it comes to alcohol and opioid and drug addiction. And it's very hard sometimes for parents to know. I think the biggest thing is if they have a suspicion, go forward on that suspicion. All right, know who your friends, who your child's friends are. Know where they are, what they're doing, what's going on at these parties, or when they're out of sight. But if you have a hunch, you may be onto something. And to monitor for those for certain drugs, not all. That's something that each family needs to have that conversation with. That there's obviously some thought that the parent's doing this testing, that's a very personal discussion that each family needs to have. Testing your child for drugs. But I think if you have the inkling or suspicion that your child is on a substance, the earlier the intervention, the better the outcome. The range of emotions on the parents is there's a wide range. I'll give you an example. We have PNC concerts, a couple times a week, and depending on the band, we'll get a large influx of young adults or even not teenagers who'll come in with alcohol intoxication. The parents, I think they're restrained in the emergency department because their child is ill at that time and undergoing treatment. But once the child is more awake and coherent, especially from alcohol, I try, and all our providers, have that conversation with the parent and the child to let them know the severity of their illness at that time, of that being alcohol intoxication, and try to warn them in a very stern and firm manner that this is a problem, even once of binge alcohol drinking. That's what I'm really concerned about, especially in these teenagers, and what that could lead to, and that even that 1 or 2 episodes, and what dangers they can get into, and that really needs to be stressed with teenagers, because that one episode may lead to a second episode, and though they may not become alcoholics, but that second or third episode, they can get into some real serious injuries and trouble. The worst is when patients, young adults, come in and they need to be not just only seen in the emergency department, but treated or intubated which is having a breathing tube put into them. That's, parents feel like a sense of failure almost, like, what could I have done? What could I have done earlier and sooner to prevent this for my child? At that time, it's just support for the parent to get them over this acute period. And then it's going to be a very long and hard intervention for that family. And it's a whole family involvement. The parents, the siblings, the community, the school, it's everyone. The child can't do it by themselves, and it requires a supportive structure to get them through this. A recovery specialist will come to the emergency department and talk to that patient and get them intervention and treatment directly from the emergency department. So they will come to the ER, talk to that patient. If the patient is willing, take them directly from the ER once they're medically stable to a rehab and recovery center. If the patient refuses, they will still be in constant communication with that patient after discharge to see how they're doing and get them the support that they need after the ER visit. We also have crisis workers in our emergency department who can assist with getting follow-up care for these patients, whatever their substance may be, to a variety of recovery and rehab centers in our area, and we'll be able to get the appropriate help that these patients need. If they need to be admitted to the hospital for an acute medical reason, then their treatment will be started in the hospital. From the ER setting, once they leave, it's really up to the rehab centers, the therapist, the psychiatrist, the recovery specialist to take over. I think there's been a very positive change in the behavior and thought and culture of medical professionals, how we characterize these individuals. Many years ago, they'd come to the ER, it's that alcoholic, let's just put them on the side, another drug overdose. We would stigmatize them. We would not show the same level of care and concern as we would for a patient who had pneumonia or a heart attack patient, and not realize the impact that we can have on these patients. Now it's, hey, these patients have a problem. Let's get them the same type of concern, comfort, and care that we would to any of our other patients with a stroke, a heart attack, a pneumonia, a broken bone. Let's get the specialists involved. Let's get them the appropriate intervention. And I think there's been more and more resources that we have gotten in the emergency department to take care of these patients. As I mentioned, from crisis workers to more involvement with post-ED care of the rehab and recovery center coming and talking with us, providing their information of where these patients can go, speaking with, when they do come into the emergency department, speaking with the families and understanding, hey, we need to help these patients. This is a great opportunity while they're here in the ER to get them their intervention. Once they leave the ER, they may go back to their ways. All right, let's try to intervene here in the ED while we have them captive. Are we going to be able to get them all? No, but even a few percentage, every patient counts. So I think we have more resources. We're more understanding of that this is a real problem, for our patients of our communities, and we need to get them the right treatment. Rock bottom is different for different patients. In the ER, it's unfortunate that we see many of these patients over and over again, and especially if you speak to the EMS and police, they'll be able to tell you even more that they go to these same houses over and over again, sometimes twice or 3 times in the same day, reverse them. Patients don't want to come to the ER. So the ER is one rock bottom for a certain group of patients. It may be a family member walking out on them, a divorce, children not speaking to them, a loss of a job, or they themselves are addicted and their loved ones or family members dies of an overdose. So rock bottom can be a variety of endpoints. The ED is definitely one of them. It's unfortunate. I feel as though as much as we intervene and we try to get them the right treatment from the ED, often they relapse. They can go to rehab. We send them to rehab from the ED, but I don't know what the exact numbers are, but I would say many of these patients require multiple rock bottoms before that final rock bottom makes them say, okay, this is the one that I'm going to get help, and or this is the one that I'm really going to make 100% effort. It's a long process to get these members of society back to not abusing their substances.